this talk of mine will be helpful to them. I'll be talking on parathyroid dysfunctions today and how to manage them. So parathyroid dysfunctions is either it can work more than what it is normally supposed to do, that is hyperfunction, or it can function less, that is hypofunction. But before we go to dysfunction of any organ, it is important to know the normal structure, functioning of a gland. So I will briefly go through the parathyroid, what about its normal status, and then we will discuss the disorders in slightly more detail. If there are any questions, any doubts, you can add on the chat box and we can take it at the end of the session. So like everybody knows, the parathyroid glands are located along with the thyroid gland. Probably that is why the name has come as parathyroid gland. And that is the only thing that is common in them, is their location and their name. Otherwise, it functions very, very differently from the thyroid gland. A very interesting thing about the discovery of the parathyroid gland, it was discovered by a very famous anatomist in the Indian rhinoceros. And look at how well he has described it in 1852. A small, compact, yellow glandular body attached to the thyroid at the point where the veins emerged. It's so accurate. These are the parathyroids, as you all know, are located very close to the thyroid. In association with the thyroid is what we can say. They are seen on the posterior surface of the thyroid gland. We have 4 parathyroid glands, 2 superior, 2 inferior, or we can say 2 right, 2 left. And they are very small, the size of a rice grain. The diameter is in millimeters, 2 to 4 millimeters. There may be some amount of variation, but this is the average. And they are well encapsulated, and they are typically slightly dull yellowish brown or tan colored. And they are slightly larger in women than in men. I couldn't find any reason for that anywhere, but it is like that. And these 4 parathyroid glands in the body have only one function, and that is to secrete the parathyroid hormone. And this parathyroid hormone, it has only one function in the entire body, and that is to control the body's calcium levels. That is all. So just to control the body's calcium level, we have an entire one element in the body among so many elements, and we have one whole endocrine system allotted to that. Development, as you must be remembering, the superior thyroid, there is a paradox over here. Superior parathyroid gland comes from the fourth branchial cleft along with the ultimobranchial body. So it is superiorly located but comes from the inferior pouch, while the inferior parathyroid glands come from the third pharyngeal pouch. They are developed with the thymus, so they go down towards the mediastinum and get arrested at the lower position in the thyroid. In fact, the consistency of the position of the inferior parathyroid hormone is more likely to be in a different location. It's not very, it can change, it can be variable. It can be found at a lower position than the usual position, which is the lower end of the thyroid gland. Histology, it has 2 basic main types of cells, the principal or the chief cells, which are the ones which secrete the parathormone, and the auxiphyll cells, which their function is not yet known. So the chief cells are slightly basophilic, they are smaller, their nucleus is larger compared to the cell, while the auxiphyll cells are more eosinophilic, larger in size. Like I said, the role of the parathyroid gland is one and only one, and is to regulate the calcium to a very delicate balance. So they keep doing that. They get a signal from the body, this is the serum calcium level, so it's gone up, down, so it releases the amount of hormone required to make it normal at all the time. So it has a very short half-life. The half-life is just 5 minutes. So this is very important in management, especially during surgery. I'll come to it later, but this fact is used very well to give good results in managing the condition of hyperparathyroidism. We will be discussing that later. So like I said, there is one gland, one endocrine system which is allotted to just manage the calcium. Why is it so important to manage the calcium in the body? You must all remember through your physiology days that for all cells to act, there is calcium channels, and it is because of those calcium channels that the cells function. Things go in and out when the calcium ions hit. So the electrical energy of the nervous system, the electrical energy of the muscular system, all this is regulated by the entry, opening up and closing of the calcium channels. And that is why it is so important. All the functions in the body are based on this. And the third thing, which you would think is, why am I not saying that? Of course, it is also stored. Calcium is required for our bone strength. But actually, this is the less important of the two other functions of the cell. At the cellular level, keeping the nerves and the muscular system intact and make them function is the most important thing. In the skeletal system, the bones just act as a storage system for calcium, from where if we can take out the nature takes out the amount of calcium required in an emergency from the bones. And if there's more calcium, more gets deposited in the bone. And if the serum calcium level is less, then calcium is taken away from the bones and brought into the system in the serum so that the rest of the systems can function properly. So though calcium is important for our bones, but it is more like a bank or a vault where it is stored for emergency. So now calcium is regulated by the parathyroid hormone. How does it do it? Let's see how does it do it. The next slide is slightly crowded, but it is very simple to understand. I'll go through it with you. Now let's start with the situation where the blood calcium level has dropped. Now the signal goes to the parathyroid hormone. It releases the chief cells of the parathyroid hormone, release parathyroid. Now this parathyroid hormone acts directly on the bones and on the kidneys. So what does it do in the bone? Now there is less calcium in the serum, so we need more calcium. So it inhibits the action of the osteoblasts and increases the action of the osteoclasts. So bone is broken down and more calcium is released into the bloodstream. On the kidney, it has two functions. First, it stimulates the kidney tubule cells to prevent calcium from being excreted in the urine. Whatever was meant to be excreted in the urine is now stopped, and the excretion of calcium is reduced, and so the blood levels rise. And the second very important thing is that it stimulates the kidney tubule cells to release calcitrol. Calcitrol is the active vitamin D or a form of vitamin D. So we get vitamin D from our diet, we get it from the sun. So, but that is in a different form. It's a calcitrol in the kidney. When kidney tubules release the calcitrol, it directly acts on the intestine, and the intestine now increase the absorption of calcium available in the food. So normal, if you calcium intake, you absorb only 20% or so of that, and the rest of it is excreted. When the calcitrol is released, increase of calcitrol, the absorption of calcium from our diet increases almost 80-fold. So that is the very important role that the kidney plays. So the kidney play two roles. One is that they reduce the excretion of calcium, and second is they release calcitrol, which increases. So you're getting more from whatever you're eating, and you're excreting out less. So both this cause it elevated, so blood calcium levels now rise. If they rise above normal, then a negative signal goes back to the parathormone, and they reduce accordingly, manage how much parathormone is to be removed. Second is, if the level of calcium increases in the serum, then calcitonin is released by the parafollicular cells of the thyroid gland. And what does calcitonin do? It has an opposite effect to parathormone on bone. So it now reduces the osteoclastic activity and increases osteoblastic activity. So now all the excess calcium which was there in the serum now goes back to the bones. So I hope everything is clear now that this is how it works. This is how parathormone, when the levels rise, parathormone released, it acts on the bone, it acts on the kidney, it increases the absorption from the of calcium from the intestine. And if it increases above normal limits, then negative feedback and release and depositing back into the bone from where it had come first. So just for a quick recap, normal calcium levels are from 9 to 10.5 milligram per dl. Normal serum parathyroid levels are 15 to 65 picograms per ml. So this was about the normal anatomy and physiology of the parathyroid gland and parathormone. Coming to dysfunctions now. First, we'll just look at hypoparathyroidism. So hypoparathyroidism, like the name suggests, is either a decrease or total absence of parathyroid secretions of the parathyroid gland. So this will now, because increase, whenever there is decreased parathyroidism, the serum calcium levels will decrease. So the diagnosis will be by checking the serum calcium levels, and then if the levels are low, then check for serum parathormone levels. If these are also low, then it is primary parathyroid, hypoparathyroidism. So causes of, why does hypoparathyroidism occur? So the single most important cause of hypoparathyroidism is iatrogenic, that is post-surgical. Out of these, you all must have all experienced that after thyroid surgery, or it could be after parathyroid surgery, which is less common than thyroid surgery. Then other head and neck surgery for any other condition, probably for cancers and things like that. So whenever there's surgery on the head and neck region, there's a possibility of directly damaging the parathyroid gland or damaging its blood supply, because like I said, they are just a grain of rice size. So the blood supply, you can imagine how small it is. All these other five causes are rare. There is a neonatal hypoparathyroidism, which is luckily quite transient. Autoimmune disorders, congenital causes, very rare. Some De George's syndrome, I do not know what that is, but that is there as a cause for congenital to fill in our causes. Iron deficiency, mainly magnesium is the condition, and vitamin D deficiency. Because vitamin D, it will reduce, if it is deficient, then the absorption of calcium reduces from the diet, and infiltration of the parathyroid glands by any condition, granulomatous conditions, autoimmune conditions, of course, something like sarcoidosis and all may cause infiltration of the gland. Carcinoma also. Carcinoma can be both ways. It could be increased or hypothyroid or hypothyroid, depending on the cell wall. So the signs or symptoms of hypothyroidism, they affect most of the body system, but mainly the muscles and the nerves. Rough skin, dry hair, hair loss, very common. Generalized conditions, can't really diagnose with that. But generally, hypothyroidism is, you'll be suspecting it sometime primary, because it will be an iatrogenic cause, so you are already alert. So these are all for chronic hypoparathyroidism. Acute cold intolerance, these are the signs of tetany, means it is very severe and very acute hypoparathyroidism. Carpopedal spasm, bronchospasm, visual disturbances, seizures affecting the CNS, numbness and tingling in the face. There are very important signs which we can elicit using these. Muscle cramps, abdominal cramps, because now the muscles and all calcium channels are not working for them to work efficiently. So the typical OBS hand is described, fish mouth, where the muscles are not contracting enough or not relaxing quickly enough. Cataracts, hypotension, if the cardiac muscles are involved, in hypotension, heart failure, and cardiomegaly. These are the signs and symptoms that can be seen with a hypoparathyroid status. These are very famous signs which you are supposed to clinically elicit whenever there is a suspicion of hypoparathyroidism. Positive shocks text sign is when you tap on the facial nerve where it exits from the tragus region in the parotid. When you tap on this, that side muscles, facial muscles may show twitching. Similarly, if we put a BP cup and raise it above the diastolic pressure, then a trousseau sign is seen where the hand muscles, fingers and all go into spasm. So these are the two signs which we can easily elicit when we suspect hypoparathyroidism. So the laboratory tests that are required is one for diagnosis, second to find out the cause, and to see the serious side effects if they have occurred. So the laboratory test to diagnose hypoparathyroid status are PTH levels and serum calcium. If both these are low, then it is primary hypoparathyroidism. So that means the parathyroid gland is not working. Ideally, if the calcium levels were low, then there would have been increased parathyroid secretion and it would have come to normal. But this is, the gland is not capable of functioning. That is why it is called primary hypoparathyroidism. So both these levels are low to indicate primary hypoparathyroidism. Vitamin D levels could be a cause of hypocalcemia, calcemia. And similarly, serum magnesium, if it is low, then also the serum calcium levels will be low. So these are to rule out the causes of low serum calcium levels. And these are the effects, like if there is a calcium channels are not working, the heart muscles will also not work. So ECG will start showing changes. Prolonged QT intervals is the commonest. Arrhythmias, some type of arrhythmias may also be seen. So management, I'm sure you would have heard of this, or some of you must have even managed post-thyroid surgery. Patient has gone into spasm or the calcium levels are very low. So we inject 10 cc of 10% calcium gluconate over 10 minutes. So 10 ml, 10%, 10 minutes. This is the dictum that we used to learn when we were residents, and it stands. And or if this does not relieve the tetany immediately, then we also give IV infusion of 10 ml of 10% per hour slowly. But this requires cardiac monitoring because if too much calcium goes, then it will again have effect on the heart. So if this works, then that is fine. After that, find out the cause, find out the parathyroid, calcium supplements, vitamin D supplements, but these are now in much higher doses than the general dose that we give to people. If the person is hypothyroid, the requirement of vitamin D is 100 times more than the physiological requirement that nowadays everybody is prescribing their patients. Or we can directly give calcitrol form of vitamin D, which is also available. Here the dose is 0.25 to 2 micrograms per day. Of course, all these situations you will need to monitor it every 2-3 days to see how is the levels of calcium as well as parathyroid, and then titrate it accordingly. Similarly, calcium supplements are also much higher, 1 to 2 grams of elemental calcium. So it is more than, but then you'll have to give it in divided doses. You cannot give it as a single or just 2 doses because the requirement is very high. If there is a magnesium deficiency, then magnesium needs to be replaced immediately, 50 millimoles of over 24 hours IV. Then because it can cause spasm, bronchospasm, cardiac effects, severe hypocalcemia and hypoparathyroidism. So it is important that there is an airway trolley at the bedside. Patient does not go into bronchospasm and have serious consequences of that. Can wear a metal alert bracelet to monitor the heart rate, which will go if monitoring is required for this patient. And later on, once he's settled and the initial tetany crisis is over, then maintenance will be a high calcium and vitamin D and low phosphate. Uh, Calcium and phosphate have a contra relationship between in the serum level and the role of parathyroid. So parathyroid hormones increase the level of calcium and reduce the phosphate levels. So if we want to do the opposite, we have to increase the calcium diet and reduce the phosphate diet. And in very resistant cases, synthetic thyroid hormone is given, but it is not easily available, and it has some uh, concerns about malignancies and cancer, carcinogenesis, and all that. So, anyway, I have had no personal experience of synthetic parathyroid hormone being administered to a patient. So this was about hypoparathyroidism, low parathyroid, because of low calcium and low calcium. The effects are all because calcium levels are low. So similarly in hyperparathyroidism, the parathyroid hormones are working too much, so they have caused a raise in the serum calcium levels. And they are independent, so it's the fault lies in the gland. So it is just hyperfunctioning for whatever reasons. We'll come to that. What are the reasons? And so the serum levels are high. And all the effects occur because the serum calcium levels are persistently high. So what are the causes? So primary cause, secondary cause, and tertiary. Primary is when the problem lies with the parathyroid gland itself. So it is producing more hormone come what may. So this, the most commonest cause are adenomas. Out of that, a single adenoma is the most common cause. So 90% of the patients will have primary hyperparathyroidism because they have a single adenoma. Chances of multiple adenomas are 4 to 5%. Similarly, just a hyperplasia of the gland, maybe not 5%, and carcinoma is very rare, and causing it could cause either hyper or hypoparathyroidism, like I said. So it raises the calcium level because the hypoparathyroid, the parathyroid hormone is secreting, and there is no feedback, is not working. So both these levels are high. In secondary, what happens is it happens when there are other causes for the calcium to be low. So when the kidneys are not functioning, they are not, so they secrete out the calcium without saving it, or they do not release enough calcitrol, so the dietary absorption of calcium reduces. In this case, the cause doesn't lie in the gland. The cause is elsewhere. So we have a low calcium level, and that causes a signal for the parathyroid to secrete more. But even though it is secreting more, because these systems on which it's supposed to act is not being able to yet maintain the calcium level. So that is why it is called a secondary. The cause is not in the parathyroid gland, it is in the other systems. And tertiary is when prolonged this system occurs, where low calcium keeps on raising the level of parathyroid, then even the calcium level starts rising. It is like flogging a horse for very long, and that is tertiary. But basically, always hyperparathyroid is when the PTH is high, and most often it is because and so you will have both these going hand in hand. More commonly, serum calcium is raised, parathyroid hormones also raised. So whenever we see a calcium report, which is more common, if it is abnormal, then it is worth always doing a serum parathyroid hormone levels. Then we'll get an idea whether it is raised or low, and take the commonest cause of hypo calcium level changes are changes in a parathyroid gland. So that is there are other causes also, but that is not the topic of discussion today. So that is it. Like I said, primary is when the fault lies in the gland itself. So it could be either adenomas, which is the commonest, hyperplasia, or carcinoma. Secondary is when the other systems on which the gland acts, the kidneys and the intestine, they are not working properly, malabsorption, alcoholism, kidney failure. Then they give signal, then the calcium level is low, but they keep on that low signal calcium level gives a feedback to the parathyroid gland to secrete more hormone, and so we have a hyperparathyroid state. There's another condition called as renal cell carcinoma or parathyroid syndrome, which is also called the increased parathyroid hormone secretion. So these are the etiology of hyperparathyroidism. Hope it is clear. I'll go to the next slide. Whenever there is raised parathyroid hormone levels, there is something we should keep in mind is, does it fall into multiple MEN syndrome? So there are three MEN syndromes, MEN1, MEN2, and MEN2A and B. So see, parathyroid hyperplasia is more common in men 1. It is also seen in men 2. So if we have a hyperparathyroid status and it is because of and we've investigated and we find that there is parathyroid hyperplasia, then it is worth remembering that is the patient also having these conditions, pancreatic tumors, pituitary adenoma, lipomas, angiopathy, or medullary CA of the thyroid gland, pheochromocytoma. So if we know some fact, we can look for it. So that is why I put this slide. So if we come across hyperparathyroid status and it is not an adenoma, it is hyperplasia which is causing the hyperparathyroid. So it is worth keeping in mind. It would be a very good thing to manage the patient properly. Correct diagnosis is the most important thing to help to diagnose the patient, manage the patient correctly. All of you must be remembering hyperparathyroidism, classically moans, groans, stones, and psychiatric overtones. So these are the symptoms. These are all because of hypercalcemia. Moans are joint pains, muscle pains. Moans and groans are because of that. The patient feels lethargic, ill, depressed, can't remember things. Sometimes the only thing is I feel I've become much older than what I am. So these are very non-specific symptoms. You may just not think of hyperparathyroidism unless you remember it. Okay, there are especially, and these status, hyperparathyroid status is seen more commonly as we age, and it's seen more commonly in women. So if there are patients, slightly elderly patients, you do not know whether they really are just complaining. Slight amount of memory loss is possible, slight amount of arthritis is possible, but kidney stones, other conditions, mental faculty is not up to the mark, should raise our antenna. We should say, check their calcium levels, and if they are abnormal, then think of a hyperparathyroid status because that is so easy to treat. And hypercalcemia also causes, like, there is more osteoclastic activity whenever there is hyperparathyroidism. So there is the bones become weaker and there is replaced by fibrous tissue, and that leads to more and more deposition of fibrous tissue in the area of the bone called brown tumors. And so if ever a diagnosis, if you come across a brown tumor, then of course you have to look for parathyroid. So it's more commonly seen in the jaw bones, usually the mandible bone. That is where I have seen it, but maybe it is seen somewhere else also. But in head and neck, it is seen more commonly mandibular area. Chondrocalcinosis, because pyruvate crystals deposit. There's more calcium in the serum, and this is deposited in the joint cartilages. So here is a graphical depiction of the clinical features. There's decalcification of the skull. It is typically called the salt and pepper skull. Giant tumors of the mandible, calcification in the lungs, parathyroid adenoma. Sometimes the patient may present with a swelling in the thyroid region, which on FNAC or something you may get as a parathyroid adenoma. Osteotic reabsorption of the subperiosteal region of the bone, kidney stones, renal infections, renal failure, muscular pains, muscular and joint pains, peptic ulcers, pancreatitis. So patient has all symptoms of all the body, almost all systems of the body. Now diagnosing. So for diagnosing the condition, whether the patient has hyperparathyroidism or not, we need only lab tests. Nothing else is required. 3 lab tests are required. Serum calcium level, it has to be high. Serum PTH level, it has to be high. And vitamin D levels, these are also high, about 30. And these all have to be, these are all fasting blood sugar level, blood level samples, and preferably in the morning. So the diagnosis is made. Once you've done these blood tests, you know the diagnosis. Now we have to find out what is the pathology in the parathyroid gland and which of the parathyroid gland is involved. All the glands are involved, one is involved, two is involved. So that is the most important thing that we need to know, which gland is involved and what is the involvement of the gland, whether it's an adenoma or is a hyperplasia. So here we need imaging to localize the lesion. More important to localize it because ultimately, most likely, patient is going to go for surgery. And imaging can be used to see the effects of hypercalcemia on the bones. These are what we will see: demineralization of the bone, subperiosteal lytic areas, resorption of the phalanges of the terminal bones, pepper pot appearance on a lateral skull, reduced bone density on a DEXA scan, kidney stones. All these can be diagnosed with imaging. Calcification in the soft tissues of the hand, cornea, arterial walls, bronchium. So these are all, this is not for diagnosis, it is for finding out the effects of hypercalcemia. So imaging, blood tests for diagnosing hyperparathyroidism and imaging to localize the lesion. Where is the pathology? So the most easiest, easily available, simple, safe test is a ultrasound. So ultrasonography is readily available. Of course, every test needs an expertise, but that is how it is. And if there's any other surrounding pathology in the thyroid, that also gets easily diagnosed at the same time. System-AB scan is using technetium 99, iodine, radioactive iodine. SPECT studies can also be done with System-AB, and they show the gland. So there are phases where you inject the radioactive material. Then there are immediate phase, both the thyroid gland as well as the parathyroid take it. Then the thyroid washes away, the parathyroid area remains, depending on 15 minutes, 2 hours, and all. But these are not as accurate as the other tests. They yet do not give, there is always a chance of error in that. So they are not very popular currently. So sonography and CT scan, among the CT scan, 4D CT scan is even better because it gives you in 4 planes. So like the thyroid, the parathyroids are very tiny glands behind a bulky gland, the thyroid gland. So imaging has to be really good, and 4D CT gives us that facility. So we can see the parathyroid, the superior ones at the in the behind the thyroid gland, and they are slightly less, they are slightly hypodense compared to the thyroid gland. And if we use contrast, then in the arterial phase they take up more than the thyroid gland, and in the venous phase they take up less than the thyroid gland. So you will come to know the number of glands involved, the exact size, their exact position. So 4D CT is currently the investigation of choice. 13F choline PET also gives us equally good in this thing, but it is probably not as easily available and also will be more expensive. So basically, these are the most popular investigations: USG and CT scan. MRI can also be done, but for this slide has come the pharyngeal terminal lytic areas, the salt and pepper appearance of the lateral skull base in hypercalcemia states. So now we've already diagnosed primary hyperthyroidism. So we have to manage it. Actually, the best way to treat primary hyperparathyroidism is by parathyroid gland surgery. Now, the surgery will depend on what it is, whether it's an adenoma, hyperplasia, 1 gland, 2 gland, but surgery is the best option. So we have to do the appropriate surgery. I'll come to that in a few minutes. And the surgery should be safe enough not to induce hypoparathyroidism after the surgery. And then post removal of the thing, the patient does recover very well. Recovery is permanent and lasting. But in the immediate post of patient, the patient has already been in a hypercalcemic state with weak bones for quite some time. So we need to build up the bones for some days or some months or maybe a year after surgery to come back to normal status. Otherwise, the hormones should come to normal. Surgery, if you take out the offending gland, usually you can get very good lasting results. So surgery is the best option, but sometimes if there is very severe hypercalcemia, then it is better to first correct that to a certain level and then opt for surgery. And this is in acute cases, wash away the calcium by hydration with saline or forced diuresis is the method for treating very severe acute hypercalcemia. So like I said, for primary hyperparathyroidism, the problem lies with the gland, and surgery of the affected gland is the best option. And this is the option if the patient is symptomatic. Can we not do surgery sometimes? Yes, sometimes if we just discover that the patient has a mildly high raised calcium levels and slightly raised parathyroid, but there are no symptoms. There are no symptoms of hypercalcemia, there is no symptoms of nephrolithiasis, then we can conserve such patients and treat them symptomatically or wait for the symptoms to come before doing surgery. But in these also, in asymptomatic patients also, there are some patients, even if they are asymptomatic, we should not wait and offer them surgery. So what are the criteria for surgery in an asymptomatic patient? Is this. The bone mass is less, decreased bone mass by more than 2 standard deviations for that age. Serum calcium levels more than, this is 2.5 millimoles per liter, but it is more than, usually it is up till 10.5 is taken as normal. So above 11.5, then you will offer surgery in spite of the patient not, you will suggest it is better to go for surgery in spite of the patient not having symptoms at present. If the patient's age is less than 50 years, asymptomatic patients are yet recommended to go for surgery. And if the patient is not possible to follow up for long-term follow-up is not available, again, it is better to do surgery than to conserve such patients. Like I said, that after the surgery, it will take time for the bones to come back to normal. So these are the things which are, we have to build the patient's bones. Surgery is one part, we remove the offending gland, now the patient's parathyroid hormone should return to normal. Even that takes around a few weeks for them to come back to normal. But after that, bone building will take even longer. So calcium rich diet, calcium supplements, vitamin D3 supplements. If there is very severe bone loss, then anabolic steroids may be considered. Calcitonin is another option to increase osteoblastic activity. Exercises and massage they always work uh, as supplements. So coming to parathyroid surgery. So all of you must have seen it. It is very similar to thyroid surgery. Position of the patient is same, head extension under a boulder, infiltration, look at, expose the gland, first expose the thyroid. The parathyroids are, upper parathyroids are usually at the level of the cricoid joint uh, and uh, and where the thyroid artery enters into the gland. And the lower ones is usually at the lower end of the thyroid gland. But that was a traditional surgery where we would do a typical thyroid gland surgery type of thing, expose all the four, see all the four glands and find out what is abnormal and then do it. But there was, every time we handle a parathyroid or touch the parathyroid gland, there is always a risk, even if we do not remove it, because it's such a tiny gland that if we damage it, if we touch it also, there's a possibility that we have damaged its blood supply, if not permanently, at least transient. And the more the glands we touch, the more damage we are likely to. So now with localization studies and lot of possible help intra, we do not try to expose all the four glands. We try to find out the offending gland pre-op and target only those glands. No need to unnecessarily touch the other glands, but keep in mind, intra-op, that the localization studies may have an error. So there are intra-op checks to see. Suppose things are not working intraopally fine, then we should be able to say, no, this case needs more exposure and we need to look at the other gland. So I'll just come to the thing. So if we already know that there is only one adenoma, we are going to tackle only that, we can do a less invasive surgery in terms of the scar being less. And of course, nowadays endoscopic facilities with magnification. And always use magnification during parathyroid surgery. Either use a microscope or an endoscope, whichever is convenient, use that. So frozen section facility, that is easily available everywhere. So take the gland, send it for frozen section, make sure that it is diseased. If it is not diseased, then probably there is some other, but the patient, now this gland that which we have received, sent to the pathologist is not diseased, but the patient certainly has hyperparathyroidism. So we need to look at the other glands in such a situation. Of course, needless to say, the surgery, the head and neck surgery, we need to have proper instruments. Bipolar harmonic scalpel is a must for the surgery. Now, how do we know? So besides the frozen section, there are very interesting, like I said earlier in the beginning, that the parathyroid hormone has a half-life of only 5 minutes. So this fact is used for monitoring during surgery. So what is done is, just when we take the incision, we send the parathyroid serum parathyroid blood sample for parathyroid hormone levels. We know it is high pre-op. So during the surgery, just before we take, when we take the next incision, not touch the gland, the levels will come as high. Then we go to the area of surgery, remove the offending gland or whatever surgery we have planned for that. We again, after 15 minutes and after half an hour, we wash time is 5 minutes. So after 15 minutes, half an hour, we again check for the parathyroid hormone. Serum blood sample we send again for parathyroid hormone levels. So this should drop by 50% of the pre-surgery level. And it should not only drop by 50%, it should come within normal limits. So normal limits, I had told you, is up to 60 picograms per ml. So now, after removing the offending gland, if it has not dropped by 50% and has not come within normal limits, then we have to look for other glands and see that maybe there is more than one gland which is diseased. Now, uh, so if that is, so if we find that this is, now we can also have one more help, which side to look for. So if we do selective venous sampling, suppose the left side gland has secreting parathyroid hormone, which is more than the right side. If we do the inferior thyroid vein or the internal jugular vein on the left and the right side separate sampling, we will come to know which side is secreting more and which side is normal. Even that fact we can know. Now, where to look? We've already localized one gland, removed it, it's not working. Now, we out of the three, which to look for? We can use selective venous sampling, and that can sometimes help. Nerve monitoring helps to prevent damage to the recurrent laryngeal nerve. This is more, it's more required for, if you have it, very good, but for revision cases, so of course, it is a very helpful tool. Um, am I audible?
Yeah, ma'am, you're audible.
Okay, so that's it. Okay, but my slide is not moving forward now. Now. So, like, let us see what happens to the when we remove the diseased gland. So now suppose this is a case of an adenoma. Now here in a normal gland, all four glands, all parathyroids will release some amount of parathyroid hormone. This will go into this, and we have the patient will have a normal parathyroid hormone level, which is for this patient say 45 picograms. Now in a case of adenoma, one of the gland has got an adenoma which is secreting lot of PTH. So what happens is that the other glands now get suppressed. So they are secreting, but not enough, less than what they normally would do. And now the patient's levels are very high. PTH is 120 picograms because one adenoma is hyperfunctioning and it's shrunk the other normal parathyroid glands have now started secretion. So what happens immediately after surgery, we've removed the adenoma. So now the patients, like I said, we have to check that the patient's PTH levels are now less than half, and and they should be within normal limits. So they've come to 22, but this is yet within normal limits. But his other glands are now have been shrunk, so they will be hypofunctioning. Okay, so we have to take care of that in the immediate period. Now this glands will come back to work because we've removed the offending gland, but they will take 6 to 12 weeks to do that. So, and this is a situation sometimes we will have parathyroid hyperplasia. So here, this is a normal gland, similar situation. All the 4 glands or 3 glands or 2 glands are hyperfunctioning. So in the case of hyperplasia, the surgery is slightly different. We remove if all the glands are hyperfunctioning, then we remove 3 glands and take a remaining one, whichever is the smallest among them. We leave a normal size of that gland back and remove all the others. So 3.5 or 3, depending on that and depending on the level. So again, we have a gland which is smaller than what it was earlier. So immediate post-op period, we will have. So that can be either for hyperplasia, we can either leave behind a normal sized piece of the gland, or it can be removed from the parathyroid area and retransplanted, auto-transplanted in the sternocleidomastoid muscle or the brachioradialis in the arm. This is usually done together, but they say you can even do it later. And this transplanted gland starts functioning within 3 months. Success rate of auto-transplantation is 50%. Okay. So now, like I said, for some days the patient, though we have removed the hyperparathyroid status, but the other glands have to yet start functioning to their normal level. So the patient will be in a slight hypoparathyroid status and his bones are already weak. So we need to take care of the post-op period, and for 6 weeks to 3 months. So a lot of monitoring is required. Initial 1 week, the patient is put on very high dose of calcium, 1 to 2 grams of elemental calcium in divided doses. Calcitrol 0.25 to 2 micrograms per day. And then every 3 or 4 days, check the levels of calcium, check the levels of parathyroid hormones, and keep reducing this calcium and calcitrol levels until it comes to normal, and then stop the therapy. Don't just say ki ha surgery theek hai, we check the levels and drop, now the patient's parathyroid hormones are normal at that level, but this needs monitoring. Post-op care is very important. Complications are like any thyroid surgery. Of course, hypoparathyroidism is one of the complications. And that is also there in thyroid surgery. Nerve damage, infection, bleeding, recurrent laryngeal nerve damage. Those are the complications. Thank you. I've finished my presentation. Now, any questions? I'll be happy to take them. Why is my video not there? I am not being able to connect to my camera, but I'll take the videos right at start. So no questions? How much interval can we give IV calcium? We can repeat it like if we have given calcium gluconate 10 minutes, we repeat the calcium levels. If they are yet low, patient is yet in tetany, we can repeat it again after half an hour or whatever, or we can, in fact, we give an infusion till the calcium comes back to normal, till normal levels, or at least the tetany is gone away. It may not come back to normal, it may come back to normal and again fall, but the symptoms of tetany, that is the spasm, the bronchospasm, the hand spasm and all goes away. Till then we give it. And we start immediately oral calcium and vitamin D. So every time the patient is in tetany, we give calcium gluconate. If it is not resolved, then we give it IV. In fact, actually calcium gluconate, the absorption is only 9 to 10% of the calcium that we give. The oral calcium, calcium citrate, calcium carbonate, more of the calcium is absorbed. But then IV, it goes directly to the blood. So just giving IV gluconate without adding oral calcium and vitamin D will not. So 10 milligrams of, it will rise by only 10%. So maybe 1 milligram. Post-op at least 2 or 3 days depending on the level. So suppose your, like I showed in that example, 22 milligrams was within normal limits, but it is likely to fall. So next day, if the parathyroid hormone levels you check, it is less than 22, then you will check it more frequently. If it has gone above thing and patient has no symptoms, so if the levels have fallen, calcium levels have fallen, parathyroid, patient will go into tetany. If the patient is going into tetany, you'll check it even twice. If the patient is asymptomatic, then you will check it every 2-3 days, but we need to check it frequently because we are giving very high doses of calcium and we need to reduce those ultimately. So the next checking will happen depending on the levels that you found today. So today's sample is this much. If it is very abnormal, you'll check it next day. If it is within normal limits, 3 days, then 5 days. That's how we do it. Post-surgery steroid only if nerve damage is suspected or you feel that, okay, you've touched too many glands, there must be a spasm for its anti-inflammatory reaction. Yes, you can give post-surgical steroid. No harm in giving that. But you should know what purpose you're giving it for. So if you're suspecting handling of the glands too much, so what happens is if we have handled the glands, like even if we are sure that there is no blood, we've not damaged the blood vessel, we've not cut the blood vessel, we've handled the gland. So some amount of vascular spasm is likely to happen. It will revert. But if you feel too much handling has happened, then as an anti-inflammatory role, steroid can be given. And for nerve damage, so it's standard. If we think we have damaged, touched the nerve, even though not cut it and all, then steroids are required. Mostly the anesthetists do give 1 or 2 doses of steroid intraoperatively. Uh, my video is not starting. I don't know what is happening. So, shall we end the session? Any other questions?
30th. Okay, ma'am.
Thank you very much and a happy Diwali once again to all and to you, sir, too.
Thank you, ma'am. Thank you all.